Welcome to MBBS Mastery. In this video, we're beginning our journey into gynecology, and our first lecture is on menstrual cycle. Make sure to subscribe and hit the bell icon so you don't miss out on upcoming lectures. Every month, the female body runs one of the most perfectly timed biological cycles. If you understand this cycle once, gynecology becomes easy forever. What is the normal menstrual cycle? Let us start from the basics. The menstrual cycle is a hormonally controlled cycle. Its main purpose is to prepare the uterus for pregnancy. If pregnancy does not occur, the lining of the uterus is shed. This shedding is what we call menstruation. The most obvious sign of a normal menstrual cycle is regular periods. This entire cycle is controlled by hormones coming from the hypothalamus, the pituitary gland, and the ovaries together. This is called the HPO axis. That means hypothalamus, pituitary, ovarian axis. Note, important point for exams. Day 1 of the cycle is the first day of fresh bleeding. Always confirm this when taking menstrual history. Now, what are the important features of a normal cycle? Let us look at the numbers. These are very important. The average cycle length is 28 days. Normal range varies from 21 to 35 days. The duration of menstrual flow is 2 to 8 days. Normal menstrual blood loss is about 35 milliliters per month. I'll give clinical tip in the lecture, so note it down. Long cycles usually mean late ovulation. Short cycles usually mean early ovulation. What is the role of the hypothalamus? Now we move to hormone control. The hypothalamus produces GnRH, that is gonadotropin-releasing hormone. But the key word here is pulsatile. Pulsatile GnRH release stimulates pituitary. Non-pulsatile GnRH release suppresses pituitary. Very important concept here is only pulsatile GnRH can stimulate the release of FSH-LH. This is why continuous GnRH analogs are used to suppress hormones in conditions like endometriosis. Think of it like this. The pituitary listens only to rhythmic knocking, not continuous noise. The anterior pituitary responds to GnRH. It releases two main hormones, FSH, follicle-stimulating hormone, and LH, luteinizing. Hormone FSH acts mainly on granulosa cells of the ovary. LH acts mainly on theca cells. Theca cells produce androgens. Granulosa cells convert these androgens into estrogen. This conversion is done by the enzyme aromatase. Learn this mnemonic: LH makes androgen, FSH makes estrogen. Feedback. Control by ovarian hormones. Now let us understand feedback. Estrogen, low estrogen levels, inhibit LH, negative feedback. High estrogen levels stimulate LH, positive feedback. This positive feedback causes the LH surge, which leads to ovulation. Progesterone. Low progesterone stimulates FSH and LH. High progesterone suppresses FSH and LH. Note. This exam point, only estrogen shows positive feedback. Progesterone always gives negative feedback. Phases of the menstrual cycle. I want you to imagine the menstrual cycle as one continuous story, not separate topics. The ovary, hormones, and endometrium are talking to each other all the time. The ovarian cycle has 3 phases. 1. Follicular phase. 2. Ovulation. 3. Luteal phase. The follicular phase, most important. This phase is variable. It determines the length of the menstrual cycle. It usually lasts around 14 days, but it can change. At the start of the cycle, estrogen is low, progesterone is low. FSH starts to rise. FSH stimulates multiple ovarian follicles. These follicles produce estrogen by aromatization. As estrogen increases, FSH starts to decrease due to negative feedback. Only one follicle survives. This follicle becomes the dominant follicle. The dominant follicle has special features. It is the largest follicle. It has maximum aromatase activity. It has more FSH receptors. It produces the highest estrogen. It secretes inhibin. Inhibin suppresses FSH further. This causes atresia of other follicles. That is why normally only one ovum is released. Inhibin and activin. Inhibin and activin are paracrine hormones. Inhibin decreases FSH, activin increases FSH. Inhibin is released by granulosa cells. Very common Viva question. Ovulation, the central event of the cycle. Ovulation means release of the oocyte from the dominant follicle. This is the most important event of the menstrual cycle because without ovulation, no pregnancy. Without ovulation, cycles become irregular. What triggers ovulation? As the dominant follicle grows, it produces increasing amounts of estrogen. Initially, estrogen gives negative feedback to the pituitary. But when estrogen becomes high and sustained, something special happens. High estrogen changes GnRH pulsatility, switches feedback from negative to positive. This positive feedback causes a sudden sharp rise in LH. This is called the LH surge. LH surge is essential for ovulation. What does LH actually do? LH does multiple things at the same time. 1. Completes oocyte maturation. 2. Weakens the follicular wall. 3. Causes luteinization of granulosa cells. 4. Starts progesterone production even before ovulation. Ovulation occurs about 36 hours after the start of LH surge, or about 10 to 12 hours after the LH peak. How does the follicle rupture? LH stimulates release of matrix metalloproteinases, MMPs, prostaglandins. These substances digest collagen and weaken the follicular wall. Pressure inside the follicle increases. Then the oocyte is released. This is why NSAIDs, which block prostaglandins, can delay ovulation. How this is clinically relevant. LH surge is detected by urine ovulation predictor kits. Mid-cycle pain, Mittelschmerz, occurs due to follicle rupture. Androgen levels briefly rise during ovulation. Luteal phase. The progesterone phase. After ovulation, the ruptured follicle does not disappear. Instead, granulosa cells, theca cells, they reorganize and form the corpus luteum. Hormone of the luteal phase. The dominant hormone here is progesterone. Progesterone prepares endometrium for implantation, stabilizes uterine lining, suppresses further ovulation. Duration of luteal phase is very important exam point. Luteal phase is constant, about 14 days. It does not change even if cycle is 21 days. Cycle is 35 days. This is why short cycles, short follicular phase. Long cycles, long follicular phase. What happens if pregnancy does not occur? Corpus luteum survives only 14 days. Then it degenerates, becomes corpus albicans. Progesterone and estrogen levels fall rapidly. This hormone withdrawal triggers menstruation. What happens if pregnancy does occur? The embryo secretes human chorionic gonadotropin, HCG. HCG acts like LH, maintains corpus luteum, allows continuous progesterone production. This progesterone maintains endometrium, supports early pregnancy. This is called luteal rescue. Now let us shift focus from ovary to uterus. What the uterus is doing. This is known as endometrial cycle. The endometrium responds to ovarian hormones and shows 3 phases. 1. Menstrual phase. Menstruation is shedding of the functional layer of endometrium. It starts due to withdrawal of progesterone and estrogen. Mechanism. Progesterone withdrawal causes vasoconstriction of spiral arteries, endometrial ischemia, tissue breakdown. Important mediators. Prostaglandin P, GF2, alpha, endothelin 1, platelet activating factor PAF. These cause bleeding, hemostasis, enhanced fibrinolysis, less clotting. That is why menstrual blood does not clot. Menstruation lasts 5 to 6 days. Repair after menstruation. Endometrial repair begins immediately. It involves glandular regeneration, stromal regeneration, growth factors involved, VEGF, angiogenesis, FGF, stromal growth, EGF, estrogen-mediated repair, 2. Proliferative, follicular phase. This phase is under estrogen control. It occurs between end of menstruation, ovulation. What estrogen does, estrogen causes rapid cell division, glandular growth, stromal thickening, epithelium changes, from single-layer columnar to pseudostratified with frequent mitosis. Endometrial thickness increases from 0.5 millimeters to 3 to 5 millimeters, spiral arteries lengthen. Important concept. An estrogen-dominant endometrium is unstable. If estrogen continues without progesterone, anovulation. Endometrial hyperplasia occurs. Irregular bleeding develops. 3. Secretory, luteal phase. This phase is under progesterone control. Progesterone stops proliferation, converts endometrium into secretory type. Changes seen. Glands become coiled and tortuous. Glands secrete. Glycogen stroma becomes edematous. Spiral arteries become highly coiled. Decidualization. In late secretory phase, stromal cells transform into decidual cells. This prepares endometrium for implantation. Decidualization is irreversible. If pregnancy does not occur, apoptosis occurs. Menstruation begins. A progesterone-dominant endometrium is stable. Now look at the diagram as one story. Follicular phase. Rising estradiol mid-cycle, LH surge. Ovulation luteal phase. Rising progesterone. Basal body temperature rises after ovulation. Endometrium thickens, then becomes secretory hormone fall. Menstruation. Everything is synchronized. This concludes our in-depth discussion on menstrual cycle. In our next lecture, we will explore developmental and hormonal disorders in gynecology. If you found this lecture helpful, please like, share, and subscribe to MBBS Mastery. See you in the next lecture.